No heart surgery is routine, but there was nothing out of the ordinary in this case. It was a simple procedure. I autoclaved the instruments before retrieving the patient from the 6th floor ICU. I double-checked his name, double-checked the procedure. It was a single bypass. I checked his vitals. Heart rate was 68, blood pressure 120/80. He was in excellent shape for the operation. I talked him through the procedure as I wheeled him down to the 3rd floor OR. He was in good spirits. He'd asked me how the Tigers were doing in their matinee game. He was a season ticket holder. I scrubbed in, I shaved his chest, and I sterilized the incision area. I draped the patient and administered the initial antibiotics. And then I looked him right in the eye and I told him not to worry, because I was personally guaranteeing a Tiger victory. He didn't believe me. I told him I wasn't guaranteeing a World Series appearance, just a victory today, and I told him he could read about it tomorrow in the newspaper. He smiled and I put him under. I got him intubated and I installed a Swan-Ganz catheter. I used properly calibrated anesthesia for a man his size, 6'2", 195 pounds. There was the Versed, the muscle relaxer, the isoflurane. No, wait, did I use Pavilon or Zimmeron? It wouldn't have made a difference in this case. From there, it was strictly by the book. I opened his chest with a sternal saw and installed the rib spreader. I opened the pericardium and used the stay sutures to hold the area open. I put the cannula in. I cannulated 2 vessels, but that's hardly unusual. There was his heart, beating like a champ. I iced it and got him on the pump oxygenator. I even calculated the proximals and the distals before going on. I kept my eye on the blood oxygen level, the blood temperature, and the coagulation profile as I harvested the saphenous arteries from the patient's leg. Maybe I should have taken the radial artery from his arm. I don't know. I had no reason to believe that one would have been less fragile than the other. But that's when it started to get harried. I noticed that there was blood pooling around the pericardium. So I applied suction to the area, but I couldn't get the sutures in because I couldn't get a light down in there to get a good view. By the time I got around to the light to get it in a better position, the patient was in a full-blown hemorrhage. I ran to the equipment cart and I got the Lamoli strong clamp, but by the time I got the clamp in place, I was out of sponges and sutures. So I ran over to the pump oxygenator, I administered 3 units of blood, and I bolted out of the OR down to central supply to get more lap sponges and sutures. I was gone less than a minute, but by the time I got back, his blood pressure had nosedived. I tried to get it stabilized with epinephrine and fluid, but I couldn't get the grafts in with the sutures while he was hemorrhaging. It was all I could do to keep running over to the pump oxygenator to administer blood that would flow out by the time I made it back to him. I couldn't clamp, hold, suture the arteries, and keep the area clear all at the same time. His blood pressure just continued to go down. The epinephrine wasn't working, so I tried Levofed and pumped in more fluids. But he had already blown through 10 units of blood, and I could not stop the hemorrhaging. I was doing all I could, and it wasn't enough. This guy was bleeding out, and there was nothing I could do about it. I'm a heart surgeon. I'm not an orderly. I'm not an anesthetist, a perfusionist. I'm not a scrub tech. I'm not the circulating nurse. I was trained to perform heart surgery, and I'm good at it. But I couldn't do everything. And I couldn't stop this guy from bleeding out. He coded at 4:07 p.m. That was probably right about the time the Indians homered in the bottom of the 9th to beat the Tigers. There are no guarantees in life. I know that, and I shouldn't have said so. This is not the way it was supposed to be.